So, welcome back, Dr. Gita Arjun, with this live conversation, which today we are going to be talking on breaking bad news, which is a very important point from both the patient's perspective as well as from the physician's perspective, from our own perspective, as to how to approach this particular situation, which one does come across some or the other time during their practice. Not every day that all the patients are going to go back hale and hearty and fine, but then there are certain situations which come up which are a little disappointing from the patient's perspective and rarely sometimes from the surgeon's perspective. So I am looking forward to your interaction on this very important topic today with us.
Thank you, Rajesh. Always a pleasure to have a conversation with you. As you said, this is something so important. And we do come across it, and at the most inopportune moments, suddenly we have to break bad news to a person. And if we define bad news, it's any information which adversely and seriously affects an individual's view of his or her future. Now, remember that we have to remember it's their view of their future. Okay, if we might think that, oh, it's not such a bad situation, why are they reacting very badly? But for that particular person, for that individual, that news that you're imparting is something which is breaking them down or causing an immense amount of pain. And we know that skillful delivery of bad news can provide comfort both for the patient and for the family. So it's important, extremely important, that we learn this. Because, I always say, you may be a kind person. Kindness may be inherent in you, but it's how you express your kindness, how you bring about, show your kindness. It is a learned skill. And this is a skill that we have to learn over the years.
Yes, because bad news, you see, from my perspective as a surgeon, what happens is if it is a very clean, straightforward surgery, patients expect a certain level of outcome at our place, and when the outcome is achieved, they are definitely happy and they are thrilled with it. But in some situations, for example, very simple thing like a patient has come with a bilateral blocked tube for cannulation and she wants to conceive. They are apprehensive, and even I get apprehensive because it is not based on my surgical skill. It is based on how badly the tubes are going to be stuck inside or damaged inside. So when I have to come out after the OT is over and inform to the husband and the relatives that the tubes are opened and she is going to conceive naturally, it's good news. But if I have to come out and I have to tell them that I have not been able to do much, the tubes are still blocked, and you can still go in for IVF or you can still achieve pregnancy, but it is not going to be easy. So that itself becomes sort of a bad news in these kind of situations.
Absolutely.
There are so many aspects that we really need to discuss about this today. And yes, please.
I do believe that this is an extremely important skill. The thing is, it's a communication skill. It's a question of how you get this information across to them without them taking it as a huge blow. And unfortunately, no medical college actually teaches you these things. That is, it is not part of our formal training. It is now being included, and now, it's a little late, but I think it's extremely important that youngsters be taught how this is to be done. And mostly, how did we learn it? We learned by watching our senior teachers and colleagues. And if we were very lucky to have a mentor who was a very good communicator or who took time to teach you how to say the right things, I think we were lucky. And most importantly, it's ethically imperative. And what do I mean by that? I mean that to be an ethical practitioner, to be an ethical professional, you have to know how to say these things and why you must say these things. It's important. You can't hide, you can't put the blame on the person. You have to know how to do this where both you and the patient are sharing in an experience. It's a bad experience, but they should understand that we are equally part of this and sharing their pain. You're not
So there are
on.
two, yeah, there are two different aspects to this. The patient aspect, and the more important part is the physician or the doctor aspect. So from my own experiences, I always know that if it is a patient who has had infertility, if it is a patient who has had some problem related to her conception, then the anxiety is much more than the bad news is actually considered as a bad news, not only by the patient, but by the entire family.
Exactly.
It's much more traumatic to the patient to know that her tubes are bad and they cannot be opened, and that shock and the disbelief that she cannot conceive naturally really makes her very upset. Compared to that, if I have to deal with a patient who has had multiple previous surgeries, and I would have to probably open up the bladder or open up the bowel, suture the bowel, and I come out and say that it's part of a surgery, the bowel has been injured but I have repaired it, they take that particular bad news much better. So
Right.
patient emotional circumstances, I think, are going to play an important role in how well or how badly they take the news related to various aspects.
See, the thing is, particularly if you're talking about in obstetrics, a miscarriage or an intrauterine death, women tend to not just, first of all, they get angry with you because, how did you allow this intrauterine death to happen to me? How did you allow the miscarriage? I did everything you asked me to do. And then, in spite of that, I miscarried. So they go into despair. And also, then, as a woman, it's almost like we have seen it time and time again. They go in for this intense guilt. There's something that wrong with me. I did something wrong. Women tend to do that. And that is something that we have to help them accept and say, it is not you, it is not what you did. And you should not build up all the pain that they're having by, saying that, yes, or at least implying that it was their fault. The other thing is, we can't forget that the doctor also gets quite affected. As doctors, we get affected by what happens when there's bad news. Suppose, let me just go back to, like, either, as you said, infertility, or a person has an intrauterine death. First thing is panic. What did I miss? What do I tell them now? Oh my goodness, I did everything, but something has happened. And then on top of everything, we say they're going to blame me, right? And just to get out of that situation, when you think that they're going to blame us, we start taking out the anger on the person and then trying to imply that they did something wrong. Especially, I always have believed that as obstetricians and gynecologists, we must champion women. We have to be their champions. We have to be their total support. We can't, if the mother-in-law comes and says, I told her not to go to office and that's why now she's got an intrauterine death, you can't nod your head and say, not say that, yes, the work caused the intrauterine death. You can kind of imply it so that the blame is no longer on you, but on the woman. Okay? We can't do that. We absolutely, this happens. This happens. Just to get out of this thing, you say, oh, she worked too hard, or she went by a flight when she shouldn't have. She did this, she did that. So as it is, the woman is in despair. Everybody is telling you why this happened, why the situation happened. And then you compound it by allowing others to say, yes, this is why it happened.
Same kind of a situation happens even, for example, one of the common complications which we face in laparoscopic hysterectomy is that because of the vault sloughing out in the learning curve, especially in the 3rd week, 4th week, the patient would come back with sometimes spotting, bleeding, PV. And the question is, why did this happen? Like, suppose she has gone in for a hysterectomy and they want an advanced procedure like laparoscopy, and then again still in the 3rd week there is a problem. It is just simple vault infection which has happened. The main concern which the woman or the patient would always have is whether it is because I have walked around too much, or whether I have done some work and I've started going to the office, because I have been told by my previous seniors that I should have rested for 3 months or 6 months. But I always tell my patients that after a week they can go back to work. So I do have to reinforce that views, and the patients do really feel that it is something which has happened because they have done something wrong, or they have been over enthusiastic about their recovery. But I have to tell them that this would have happened even if you would have been on a complete bed rest for 3 weeks. So
Right.
then it takes a little while for them to realize that, okay, this is something which is part of the healing process and something which can happen any which ways. I
Right.
guess the same thing happens for all types of situations that we actually come across when we are dealing with these bad news kind of situation. So I would want
Right.
you to kindly highlight, how does a physician or a doctor prepare to deal with this?
Right. So, as I said, one is, of course, in obstetrics, I already gave the example. Sometimes in an infertility, you talked about, if you have to tell a couple that he's azoospermic, right? It requires a certain amount of sensitivity, little amount of kindness to talk to them about it, give them what are the tell them what are the other options. If somebody, you have somebody coming in with an ultrasound which shows a complex ovarian cyst, you have to start preparing them right from the beginning for malignancy, but you can't say that word right away. It should be the first thing. So the ABCDE of breaking bad news, and this was I'm quoting Rabo and McPhee. They did. I love this paper because how do we break bad news to help patients who are suffering? Advanced preparation, build a therapeutic environment, communicate well, and I think that's extremely important. Deal with their reactions, encourage and validate emotions. And we can talk about each one in turn. So, when it comes to advanced preparation, what you have to do is make sure that you think over what you're going to say to them. Right? So let's see, we have got somebody with a complex mass, and already the person during maybe in the ultrasound or the MRI has said, "Oh no, no, go quickly and see the doctor. This is an emergency. You got a tumor. You got." So they come absolutely frightened. At the end of your entire conversation, once you have examined them, you have talked to them, the first thing they will ask is, "Do I have cancer?" Right? Because that's the first thing they're
Very
worried about. It could be a hemorrhagic cyst in a young girl, but because it's a complex cyst, they say, "Is it cancer?" So, how do we manage it? You have to think over. These are things that you have to think before, instead of just shooting out words. You have to say, Look, there is a complex mass. If there is, looks like it's a tumor. It could be anything. Let's do further tests and then let's come to a conclusion. Is it cancer, doctor? Is it cancer?" I said, "There's no way I can say it. It does not look like cancer if you think it's a hemorrhagic cyst. I can't say anything right now. Let's look at it." And as long as they know that you're with them, helping them, walking your way along with them in their path, they're willing to wait. Okay, of course, there are people who have Googled, they'll talk to their aunts and uncles and somebody in the US, they'll make all
yes.
the phone calls. They've got all kinds of information already. But still, and when they throw those things at you, you can't lose your temper and say, "Am I the doctor or are you the doctor?" You have to realize that they're anxious. Okay, they're anxious and therefore they're doing all this. So you keep sticking to the thing. I need more information before I can say. So first you use the word cyst. The next time you say the word tumor. The third time you say, "Yes, it looks like you need surgery and you may require to use something more. You might have to have further treatment." By that time, they have also understood that we are going towards malignancy, right? The second
Very
thing is,
true.
yeah, is building a therapeutic environment. Now, I don't know how you do it, Rajesh, but for me, it's always the patient first. And we see them only as a couple. First thing is to have the couple there, not just having the whole family standing there, because then you have this entire bunch of people. The couple will actually be sitting there quietly, not being able to ask any questions, because everybody around them is asking all the questions that you don't need to answer. That's one. And the second thing is, never send the woman out of the room. Family will say, "No, no, no, don't tell her, she'll break down. Don't tell her, she won't be able to handle it." Women are strong. Okay, most people are strong when it comes to themselves and they know how to deal with it. Sending the woman out, she will be standing outside and be terrified because she won't know why she has been sent out. So never send the patient out. Always keep her there as part of the conversation.
True. This is what you had mentioned just now, that it is important to be able to talk to the patient and her husband individually or in the beginning. This is very true. Common situation. I mean, you cannot really talk about whatever outcome. I mean, it's not just about a bad news. I feel that even if I am doing a surgery very well, I would not want to come out and announce in the hall that the surgery has gone off very well. I also have this approach that I would come back to my chamber. I'll get the relatives to come into my chamber, and I would just inform them that okay, surgery is done, it has been done well, and there is
Right.
absolutely no problem. But this really is something which you have put across on the screen, that you need to be able to have some sort of a decorum, I would say, or privacy, that every individual situation
Yes.
belongs to that individual alone.
Correct. Absolutely.
Yes, let's get back to the third point, what we were talking about.
Yeah. So communication. There is no two ways about it. You have to communicate, and you have to communicate with kindness. Okay. Especially when it comes to giving bad news. You, first of all, as I always said, practice the words in your head. Okay. Because people don't understand things. I remember once I had the case sheet in my hand, and I put it down on the table while I was talking to the person, to the to the couple. And this paper, because it was a polished granite top, it went, skimming along. And I just grabbed it, pulled it back. Few months later, they said, "Oh, you were so angry, you threw it at us." Right? So people tend to add things to what
Yes.
you're saying. So you have to be very, very careful. Pick your words. If you have a doubt, call a senior colleague and say, "Listen, this is what I have to tell somebody. How do I handle this?" There's no harm, there's no shame in that, because people have experience, they have gone through all this. So you can ask somebody, "What do I say?" And one of the things that I always did is, especially when things went wrong, I had my younger colleagues with me. They had to learn how I said things, because I didn't want them to learn it by mistake, by learn and error, and by error and finding out how to say the right thing. I said, "Stand here, listen to me, so that, because I've already been through this, I know what." So it's very important to communicate well, communicate clearly. Don't use colloquial terms. Don't use terms. Don't say chemotherapy. Say we have to give you medications which will help the tumor shrink down. Don't start using words which they will not even understand. "I have to do a salpingo-oophorectomy." What do they know about a salpingo-oophorectomy? "I have to remove your uterus, I have to remove your
Yes.
ovaries, I have to remove your tubes." They may not even know what tubes are, right? So you have to be very careful about what words you use.
Important points is what plays sometimes in my minds also is to be able to put across something which I know that they are going to go and re-verify with other consultants.
Yes.
Uh,
Yes.
simple aspects, like if I have told them that no, this is quite a bad uterus, Asherman syndrome, and she is not likely to conceive, I need to be a little prudent in giving a conclusion that she will never conceive. I have to
Exactly.
be very wise enough to say that this looks unlikely that she will conceive naturally,
Correct.
because
Absolutely.
otherwise it falls back on me, and then there are some surprises which suddenly spring up.
Oh,
The
yes.
moment that you tell a patient who has been having some infertility problem that you are not going to conceive, she is very likely to come back in a clinic and tell you that, see, you told me no, but I was able to conceive.
Oh my goodness,
So
yes. I remember a 38-year-old who had a frozen pelvis. We did everything, tried to free everything. And in the end, I said, "Yes, let's try," but all that stuff. She never had a period after the laparoscopy. She never got a period. She was pregnant. So it's just, yeah, as you said, you can't specifically say never, never use the word never. It cannot
yes,
happen, things like that. And don't say things like, "You've got a ovarian tumor, you've got 6 months to live." You know that people can live with an ovarian cancer for 8 years. There are people, there are exceptions. Most will not, but there are people who have exceptions. And also, don't cut off their hope. You mustn't cut off their hope for what can come further.
actually the next point, that we need to be able to encourage and validate their emotions also.
Yes. So the thing is, we have to learn how to deal with reactions. When you tell a woman she's got an intrauterine, oh no, let's go to another. A 23-year-old girl just married 6 months ago. She comes in with a miscarriage. She and her husband are devastated that they're losing this pregnancy, right? You can't say, don't sit there and cry, you're only 23, you will have 6 children. No, do not diminish her grief. Okay, don't play it down. For her, she has lost a baby. It may be a 6 weeks pregnancy, but she has lost a baby. So help her deal with that. Help her understand her grief, and then gently over the next few weeks, as you see her again and again, explain to her that yes, this has happened, but her chances of having, you know, that after one miscarriage, a chance of having another miscarriage is only 70%, or I'm sorry, 80%. After two miscarriages, her baby, her chances of having a baby is still 70%. Maybe I said that wrong. The first one, if you have lost only one baby, you're like every other woman. Your chances of having a full-term natural, a full-term normal baby is 80%. With two miscarriages, it's 70%. So when you give them these numbers, they have hope. They know that they feel encouraged. So you have to deal with the reactions, and you have to validate their emotions. You must understand their emotions. Don't play it down. If they're angry with you, don't get angry back. Okay, it's very difficult. There are
Yes.
situations where patients can get under your skin. They will keep saying certain things and they're just waiting for you to lose your temper, and occasionally we do. Okay, after being again and again repeatedly kind and repeatedly understanding, when they do that, then at that point you can say, you know what, I think this is where we need to maybe get a second opinion. Do you want to go see somebody else who will understand and will explain to you? Do you want to get a second opinion? I think there's nothing wrong with that, because at that point to get angry and say, I don't think I need to see you, you need to leave my hospital, I never want to, it only builds up bad relationships, gives you a bad name. So you have to learn to understand why they're angry. So,
It does happen. I mean, even at my place, it does happen that if there is something which is, for example, like a recurrent chocolate cyst, a patient would come back. I've operated, and they would come back with a recurrent chocolate cyst, and I have to explain to them that this is something which can happen. Though she is young and you're trying to conceive, a chocolate cyst is something which can come up again. We do really need to operate again. The fact that she has to undergo a second surgery while she is not even conceived yet, that itself becomes a big issue with the family. And then, though in spite of whatever opinion a patient might take, the fact remains that the surgery has to be done again. And I really need to sometimes keep the patience and the calmness that fine, they are going to be upset, they are going to be angry, they are going to be a little reluctant. They do ultimately come back to me to get operated.
yeah,
But you have to take that in the stride and bear with them, with their emotions, and console or encourage them. I mean, there is
right,
no other option. It's not something which I can just brush off, that this is not in my hands and I am not responsible for it, so I cannot do anything.
right.
It doesn't serve any purpose to be to the point to that extent.
Right. See, one of my patients who had, I think in her third pregnancy, I told her, you already lost two pregnancies. It is because of cervical insufficiency. You need to have an abdominal cerclage. She had her fourth, fifth, sixth outside, lost all of them, and she came back for the seventh. I can easily say, I don't want to take care of you. You didn't trust me. You've lost all this. I walked her through that seventh pregnancy, gave her that baby, and sent her home. But the thing is, they do, they do tend to, and in the meanwhile, I also see papers that in the seventh pregnancy, she has had her second, third, fourth, fifth opinions. Each one is telling her, take this hormone, never get out of bed, do all these things. And in spite of our explaining to her that all she needed was an abdominal cerclage. And in the seventh pregnancy, we did give her a baby and she went home. So at that point, you cannot take your ego, let your ego come into play and say, I will never take care of you. As you said, chocolate cysts, we know they're notorious. They can come back again and again and again. And it's not because you didn't do a good job. Your mic is not on.
So to end our session, I would request you to put up the concluding messages for the people who are watching us.
Right. See, breaking bad news, I think, is something, it's a skill and it has to be honed over the years. And I believe that the best way is that youngsters, right from medical college, should be taught how to do this. And I remember when I was in medical college and I was an intern, and there was a stillbirth. I had just joined maternity hospital as an intern, and they asked me to go out and tell the family, okay, this is a stillbirth. And I think it was so wrong, because it is I had no skill in saying that. I have no life experience. I don't know pain. I don't understand grief, because I was just a 20-year-old. So I believe that when we have to break bad news, don't send the junior most, send the senior most. The person who can actually explain and give them, with honesty, give them the news, but don't take away hope. That's very, very important. We have to be also empathetic. Okay. And there are situations when we have seen somebody lose a pregnancy again and again and again. You get very emotional, but breaking down with the patient, crying with the patient doesn't help. Okay. They lose hope. They feel, even if the doctor is crying, if the doctor is also sitting there and crying, or, you say, I think now that you have the ascites has come back in the ovarian cancer, you can tell them, this has happened. This is the time that you need to finish all the things that you wanted to do. If you wanted to go and see somebody who have not seen, one of your nephews or your nieces, or you want to go to a particular temple that you always wanted to do, just check these off your list. So tell them all this with empathy, but you don't have to sit down and break down. Okay. And the thing about Rajesh, as I grew older, I found that I was more easily upset, because when you are young, you feel you can deal with anything and all medical problems are easy to solve. But as you grow older, you realize that certain things, even the best doctor cannot handle. Okay. But there's no question of breaking down. And also be kind and always be invested in what the person is going through. Okay. And as I said, kindness needs to be expressed. You need to tell the person, I am with you. You have to learn the words, you need to learn the grammar, you need to learn the syntax of kindness and empathy. And I think that's extremely important. And it's something that we have to think before we meet the person. What am I going to say? How am I going to bring them hope and certain amount of encouragement, and not put them into severe despair?
Yes, very true. I think from my perspective, what is most relevant in this point is the hope that the patients have, because from surgery perspective, it's usually related to something which is related to conception and further fertility. So that hope part plays a very important role, that however bad the situation may be today, there are always options available. So the moment they hold on to that part, that there are always options available, there will be something which will be worked out.
Right.
The current bad scenario does not play that much of a important role, because the immediate vision goes to the next option available.
Correct.
I guess this really is very important point. And as you mentioned in the beginning, something which has to be learned out of observing other people, because not taught in medical colleges, not a part of a curriculum, but a very important part of almost a day-to-day practice which everybody faces.
Yes.
Thank you very much, Dr. Gita Arjun, again for your wonderful insights and sharing your life experiences with us on this platform.
Thank you, Rajesh. Always a pleasure. Always a pleasure.
Thank you.